Thank you, sir. And a big thank you to our chairpersons as well. Ladies and gentlemen, next up we have the last symposium for the day, the sixth symposium, the NMOSD Symposium, and I cordially invite the chairpersons, Dr. Ajanta Kesavaraj and Dr. Surangi Somaratna, to introduce the speakers.
Ladies and gentlemen, it's my pleasure to introduce our next speaker, Professor Eoin Flanagan, Professor of Neurology and Chair of Division of Multiple Sclerosis and Autoimmune Diseases at Mayo Clinic, Rochester, Minnesota, USA. He also serves as a Program Director for Autoimmune Neurology Fellowship. Today, Professor Flanagan will be discussing on evolving paradigm in NMOSD from biomarkers to breakthroughs. His experience in neuroimmunology and significant contribution to the understanding of NMOSD make him an invaluable voice on this topic. Please join me in welcoming Professor Eoin Flanagan to the stage.
Thanks so much for the kind introduction, and delighted to be able to talk to you on a disease that we've really done a great job with scientifically in terms of developing a biomarker and now some highly effective treatments. These are my disclosures here. I was involved with some of the clinical trials for NMO at the Mayo Clinic, and we'll be discussing some of those treatments too. So the origins of neuromyelitis optica was first described by Eugene de Vic in the late 1800s, and this was a 45-year-old woman who had urinary retention, paraplegia, bilateral blindness, and optic disc edema or papilledema. You could wonder, actually, if this patient could have had MOGAD, because they have the bilateral optic disc edema, urinary retention, and paraplegia, which we can see with MOGAD also. But they had on pathology spinal cord and optic nerve disease without brain involvement. And this was initially labeled as de Vic's disease, although his student Galt, I think, was also involved in the initial description. Later on, the term neuromyelitis optica, reflecting the spinal cord myelitis and the optic nerve optica, was a term used, but we did recognize that some patients would only have recurrent myelitis or would only have recurrent optic neuritis, and therefore the term NMO spectrum disorder was made to highlight that not all patients will have both myelitis and optic neuritis, and there are some other features that we'll go through. It's been a kind of an interesting time, and I'll give a few little anecdotes around this. So initially in 1999, Dr. Brian Weinschenker and Dr. Dean Wingerchuk at the Mayo Clinic reviewed a case series of patients that had fit the clinical description of this neuromyelitis optica, and they tended to have longer lesions in the spinal cord, and they tended to have more severe presentations and more coexisting autoimmunity. And in fact, they were presenting at one of the Friday subspecialty conferences at the Mayo Clinic, and Vanda Lennon was in the audience, and she came up to Brian Weinschenker and Dean Wingerchuk after the fact, and she said, "Why don't you send me some samples to the neuroimmunology lab, because I think that we could look and see if there was an antibody associated with these conditions." So that was how it initially started, and I always highlight to our trainees the importance of attending these lectures, stimulating ideas, and fostering collaboration. Around the same time, Dr. Lennon then got in touch with Claudia Lucanetti, who worked in the neuroimmunology in pathology of multiple sclerosis and demyelinating disease. And she went and looked at those cases that had biopsies or autopsies. And what she found was that there was prominent antibody deposition and also complement deposition. And this suggested, one, that this might be an antibody-mediated condition, and two, that complement may play a role in the pathogenesis. Then in 2004 and 2005, as Dr. Dalma mentioned earlier, the aquaporin 4 antibody was discovered. This was the initial pattern that they saw on the tissue immunofluorescence with capillary staining, peel and subpeel staining. And the antigenic target to aquaporin 4 was found because there was also some staining within the kidney, and that gave a clue to the localization. Subsequently, we've evolved to use cell-based assays, which offer higher sensitivity and specificity, where we have human embryonic kidney cells and we transfect the receptor of interest onto the surface. Then there was a big explosion of studies in the field of NMO, stimulated by this antibody discovery, because now you could get cells with aquaporin 4 on the surface, and you could go back to the laboratory and see what happens with those cells. And what they found was that when you added the antibody to those cells, some of the cells would die, but if you added complement in the mix, all of the cells would die much more quickly, suggesting that complement was important in cell killing and probably important in the pathogenesis. In the meantime, there was other studies looking at the importance of CD19 B cells and CD20 B cells, and also the importance of interleukin-6 in the plasmablast production of some of these antibodies, suggesting that interleukin-6, CD19, and complement may play an important role. So this then led to the next stage was the development of diagnostic criteria. So Dean Wingerchuk then led an international group that developed the first real international diagnostic criteria for NMOSD. And these are currently being revised, and Professor Fujihara will talk about that in the next talk. And later in the talk today, I'll talk through how targeting of these areas that they found were involved in the pathogenesis has led to very successful treatments. In terms of the epidemiology, in the USA, it's about 4 per 100,000 in our region in Minnesota, but it seems to be higher in Martinique, which has a larger black population, and it was up to 10 per 100,000 in Martinique, suggesting that there's a higher risk in that population. This was a study from here in Sri Lanka, showing a prevalence of 1.3 per 100,000. And disabling vision impairment was mentioned in the last talk, and that's an important disability. Disability accumulates very fast with aquaporin 4 positive NMOSD, so important to get in with treatment early. The female to male ratio we recently have looked at in a big data study looking at many thousands of patients with aquaporin 4 antibody positivity, and it looks like it's about 6.2 to 1, so females really dominate this condition. And the median age is aged 30 to 40 years, but children can occasionally have this. It's less common than MOG in children, but older adults can also have NMOSD. You can also see coexisting lupus or Sjogren's syndrome or even antiphospholipid syndrome in these patients, and they may be at increased risk of clots. Myasthenia gravis was also mentioned, I think in one of the earlier talks, can predate NMOSD. The aquaporin 4 antibody assay has evolved over time, as I mentioned earlier. This was a really nice study by Paddy Waters, and each row here represents a single patient. And what you'll see over here is this is our initial tissue immunofluorescence test, where we picked up about half of all NMO cases. But as we moved along the line, initially there was an ELISA test, and then subsequently that was a bit more problematic because it had a higher risk of false positives and it was not as sensitive. And when you moved on to the live cell-based assay, you really got optimal sensitivity and extremely high specificity. Very few false positives with the cell-based assay of aquaporin 4. This is just a study cautioning the use of ELISA. This was a study from the University of Utah. And what they showed was that patients with low or moderate positive ELISA often had false positives. Indeed, low positives, all of them were false positive results. So it's important to consider cell-based assays when you can. Dr. Sean Piddock led a nice study showing how you can potentially bring testing to the developing world. This was in collaboration with a group in Sri Lanka, where you would have a blood spot test. So just like in a child, a newborn, you have a heel prick test. You put the blood on the card and then you can assess it. With this blood card, you can just do a pinprick and then put it on the card, and then you can keep the card at room temperature and you can mail it to us, and we can extract it then and do a live cell-based assay, and it's about 85 to 90% as sensitive as a regular blood test. But you don't have to have all the storage and centrifuging that you would need with samples, so very useful for rural parts of the developing world, because there's a high suspicion that there's probably a lot of NMO in the continent of Africa where we don't have much access to testing. There's also an IDOT test that was developed by Ho-Jin Kim in collaboration with the Chinese group that also looks potentially promising as an on-the-spot test that you could do to make it easier to get access to testing in the developing world. There has been some interesting studies looking at serum GFAP as a potential biomarker. This was Orhan Akkas led a nice study looking through the inebilizumab clinical trial data, showing that there tended to be an increase in serum GFAP around the time of attacks, and wondering if you could use this to predict, and potentially if there was ways to easily assess GFAP, could you do regular sampling and pick up patients who are likely to relapse? Or could you use a GFAP as another marker of relapse adjudication for a patient where the MRI is not clear or other aspects are not clear? You may be able to use GFAP to help determine if there was a true attack. So what are the cardinal clinical features? What I think about as the three cardinal clinical features are optic neuritis, which we heard about excellently by Dr. John Chen in the last talk, transverse myelitis, which is often longitudinally extensive, and then the area postrema syndrome, which is a very interesting manifestation of this condition because aquaporin 4 is highly localized in the area postrema, the vomiting center of the brain. And oftentimes this happens as the initial manifestation, so patients may initially present to a gastroenterologist with intractable nausea, vomiting, and hiccups. They undergo a big GI workup, and then eventually they develop optic neuritis or myelitis, and the neurologist is called in and the diagnosis is made. But it can happen as a relapse, so it's important to watch out for that. And sometimes you can have signal abnormalities within the area postrema. Other clinical features can occur. You can get peri-third ventricular lesions accompanying with hypothalamic involvement, so you can get narcolepsy, and sometimes then SIADH has been seen with aquaporin 4. We also see that with LGI1 antibodies, as we mentioned earlier. You can have brainstem and cerebellar involvement, and commonly after the episodes, these patients will get tonic spasms in up to 50% of myelitis cases, where they get flexion contractures that can last a minute or so, and often very responsive to carbamazepine. So watch out for these tonic spasms following these episodes. Sean Piddock led a study showing that the lesions, brain lesions, when we do see them in aquaporin 4 positive NMOSD, they tend to follow the localization of aquaporin 4 within the brain in the circumventricular region, so around the third and fourth ventricles, and around the lateral ventricles you can see signal abnormalities. We recently reported on cerebellar involvement in aquaporin 4 positive NMOSD. This is not very well covered in the initial diagnostic criteria, but you can see dentate nucleus involvement, and we've had some patients who developed hypertrophic olivary degeneration secondary to that. We can also see involvement of the cerebellar peduncles, and often it occurs in conjunction with brainstem involvement. Some of the other MRI features and MRI biomarkers, I'll just give a few examples here. We can see these peri-third and peri-fourth ventricle lesions. Sometimes on your sagittal image of your spinal cord, if you look up top, you'll see signal abnormality in the area postrema, or on your axial brain image, you can see that. We can see involvement of the cerebral peduncle into the internal capsule. We can see this arch bridge pattern of splenium of the corpus callosum involvement. We can have white matter lesions within the brain, and we can have this linear ependymal enhancement that's been recognized, where it looks almost like a ventriculitis in some of these patients. In the spinal cord, we can see longitudinally extensive T2 hyperintense lesions. Sometimes they have a brighter area within the lesion that looks almost syrinx-like, so we call that a bright spotty T2 lesion. So it looks almost like there's a syrinx within the lesion. And then sometimes you can get a ring of enhancement, like you see this elongated ring of enhancement here. You can also have shorter lesions of NMO. So here you see a lesion extending less than 3 vertebral segments. This is seen in about 15% of cases. So they're often more central on axial images than the peripheral lesions of MS. And then in follow-up, after one or multiple attacks, you'll often see spinal cord atrophy and residual signal abnormality. Dr. Chen covered some of the MRI features. They can often involve the optic chiasm, as he mentioned. I won't go through this in more detail. And he covered OCT pictures. And here, a new technique that's coming through is optical coherence tomography angiography, where you can look at the density of blood vessels. And what we tend to see with aquaporin 4 is that there's a reduction in density of blood vessels after an optic neuritis attack. But more to come with this. I think this is just in the early stages as a biomarker. In terms of the laboratory features, the CSF often shows a pleocytosis. Sometimes you can see a neutrophilic or eosinophils can be prominent, and oligoclonal bands are seen in about 15% of NMOSD compared to 85% of MS, so an easy way to remember 85 and 15 being 100. We've seen occasional cases of paraneoplastic NMOSD in older people, so sometimes we'll screen with CT chest, abdomen, pelvis if an older person develops NMOSD. We've seen a wide variety of tumors, and sometimes if you stain those tumors, you may see aquaporin 4 within the tumors. The diagnostic criteria will be covered in the next talk, so I won't really go over this too much, just to highlight that there are criteria for with aquaporin 4 antibodies and the seronegative group. And like Dr. Rani mentioned earlier today, with seronegative autoimmune encephalitis, you got to be very careful when the antibody is negative, as there's a broad differential diagnosis. So other conditions like sarcoidosis, MOGAD, MS, you got to be very careful to discriminate all of those. In terms of treatment, John Chen mentioned this earlier as well, but steroids are going to be very important, and also in general we have an extremely low threshold to use early plasma exchange with these patients. So usually in most patients we should be using both steroids and plasma exchange for acute attacks of NMOSD. Brian Weinschenker did a nice study in 1999 showing the benefit of plasma exchange in refractory CNS demyelinating disease. This was before the aquaporin 4 antibodies were available, but I suspect that many of these patients had NMOSD in that trial. Dr. Chen went through some of this plex, so I won't go over that in more detail, but just move on to some of the attack prevention treatments. Just to highlight, there's a difference between an FDA-approved medication and a medication that has proven efficacy. And we see this a bit in MS, where rituximab works very well, but the pharmaceutical companies who don't apply for approval for rituximab because financially there can be benefits to other medications. And in NMO, this was the RIN1 study that is class 1 evidence showing benefit, highly effective rituximab in this study compared to placebo, although there was a smaller number of patients in this study compared to some of the other studies. But bottom line is that rituximab is a good medication for NMOSD as an attack prevention treatment, and there's class 1 evidence, and now that it's on the WHO list of essential medicines and with biosimilars available, it's a really good option and really should be considered the first line ahead of azathioprine or mycophenolate. There have been some studies looking at the long-term efficacy and safety benefit and the risk of de-escalation. Rituximab does seem to be quite effective and more effective, as I mentioned, than the oral immunosuppressants. There have been some studies with de-escalation of rituximab in NMOSD, showing attacks may occur in 10 to 20% over the subsequent many years. But I would be cautious about withdrawing treatment in these patients. The attacks can be quite devastating and leave a patient permanently blind or paraplegic. So we're very cautious about de-escalating treatment in NMOSD, and most of our patients we keep on long-term treatment. In terms of some of the other trials, this was complement inhibitors. We mentioned earlier that the study showed complement seemed to be involved in the pathogenesis, and this repurposed medication from paroxysmal nocturnal hemoglobinuria really showed very high efficacy in preventing attacks of NMOSD. I know that this medication is very expensive and is not currently available, but eventually this medication will go off patent, and it may be available as a biosimilar into the future. So when these medications become available, they'll be really effective for the population here. The main risk with the eculizumab medication, eculizumab is a monthly dosing, and the main side effect that you have to worry about is meningococcal infection, because if you remove complement, there's a risk of Neisseria meningitis, so that's a potential risk. Ravulizumab, this was another study led by Sean Piddock, where they compared to a historical placebo group, and there were no attacks in this study. It was highly effective, but a couple of patients in this study did have meningococcal infection. The benefit of the ravulizumab is that it's once every 8 weeks, so it's less frequent dosing. So that's useful for this. The eculizumab is every 2 weeks, so you go from every 2 weeks to every 8 weeks is more convenient for patients. Inebilizumab is a CD19 blocking agent. There's some suggestion that if you target CD19, you may get more broader immunosuppression. Dr. Hartung had a lovely image of the different B-cell subsets, and as you go to CD19 is localized on plasmablasts, which don't tend to have CD20, so you may get more broader B-cell immunosuppression and less antibody production potentially, but you may also get an increased risk of side effects with increased hypogammaglobulinemia. In this study, inebilizumab, again, highly effective at attack prevention versus placebo, but a risk of hypogammaglobulinemia in the long term. There was 2 studies here looking at the IL-6 blocking agent, satralizumab. I know that may not be available here, but tocilizumab is a similar agent that's available as a biosimilar that likely would work similarly. And again, satralizumab was also very effective. This one can be given subcutaneously at home, so patients don't have to go to the infusion center, and tocilizumab is also available subcutaneously. The main risks of IL-6 blocking agents is it can cause some hyperlipidemia, so you need to follow their lipid levels. It can cause some blood cell changes, so you need to watch out for neutropenia. You can get hypogammaglobulinemia, and there can be a risk of diverticulitis and some GI upset. And this was the other study. They had 2 satralizumab studies, again, both showing high efficacy. So what does this mean for our patients with NMOSD? If we look at the disability here on the y-axis, if we think of a patient with NMOSD, and this is time on the x-axis, what we see is they have a severe relapse, they have a myelitis episode, maybe they're wheelchair dependent at their nadir. Historically, this was what was happening. They would improve. They would be dragging one leg after one attack. After 2 attacks, they're using a cane. After 3, a walker. After 4, a wheelchair. After 5 or 6 attacks, they could even be dead. Up to 33% had a risk of respiratory failure in that initial study. So without any disease effective medications and just with steroids, you rapidly accumulate disability. If you come in and you use early plasma exchange in these patients, potentially you can enhance the recovery from that attack. So after 1 attack, you've got minimal disability. After 2, you've got mild. After 3 attacks, you're dragging 1 leg. After 4 attacks, you're using a cane. So rather than being in a wheelchair after 4 attacks, you're using a cane. And then if you get a highly effective attack prevention medication like the ones we mentioned, then after 1 attack, maybe you've got minimal disability. And then you've used your early plex, they've recovered well from that attack, and then they're not going to have any further attacks because these medications are highly effective, or maybe they have maybe very rare attacks, but there may be some risks of immunosuppression and infections that you have to deal with over time. So this impact on long-term disability from turned NMO from a disease that was rapidly disabling and fatal in up to 1/3 of cases after 5 years to a disease that patients can live a long and healthy life, although risk of immunosuppression in the long term, but that the benefit far, far, far outweighs the risk. And when patients accumulate a lot of disability, their risk of infection also goes up, so there is a risk to not using the treatments. So in conclusion, these are some of the treatments that we consider for aquaporin 4 positive NMOSD. We can see the ones here with class 1 evidence, including rituximab, and then tocilizumab may be a good alternative in this region of the world. Mycophenolate and azathioprine, I think, less useful. If you have access to the other medications, I think I would start with one of those first. And some of the infectious complications are summarized here for your reference. And I will stop there, and I'll be happy to take any questions. Thank you very much.
Thank you very much, Professor Eoin, for your comprehensive talk on biomarkers in NMOSD evolving paradigm. Now the floor is open for questions.
Wonderful talk. When you sort of have a MOG refractory patient, sorry about this, a different topic, but then I used a Tosili to control the disease, and then the patient developed neutropenia. How safe to restart Tosili?
To start tocilizumab?
Yeah.
In a patient with neutropenia?
Yes.
Yeah, I don't know. Sometimes I think with some of those side effects, you can reduce the frequency of dosing. So it's given subcutaneously once weekly or once monthly IV. So sometimes we've adjusted the dosing to try and change it. Otherwise, it might depend on the severity of the neutropenia, or if they're developing infectious complications, then you might have to switch over to a different medication. You know, the hypogammaglobulinemia is easier to manage because you can give IVIG. For neutropenia, I don't know that you can give, GCSF or something like that. We've given it transiently in some patients because they were trying to enroll in a trial and they had low neutrophils for some of the MOG trials. But I think I would it depends on the severity, and then you could space out the dosing or may have to switch agents. Yeah.
When it comes to disease-modifying drugs and pregnancy, which is the safest in your opinion, and how safe is rituximab?
Yeah, so there's some data suggesting, probably best studied more recently in the neurological literature in ocrelizumab, but probably similar with the other B-cell, that you can dose before somebody becomes pregnant, and the effect is longer lasting than just 6 months. So oftentimes it will last up to a year or a year and a half. And it seems like if you dose it a month before, then there's no exposure to the medication and just the effects of the medication. And when they've looked at babies, they've not really found much frequent hypogammaglobulinemia or issues with response to vaccinations, which is a potential concern. So I think that's one option. Azathioprine has traditionally been reasonably safe during pregnancy in the rheumatology literature. And also for eculizumab, there's a lot of literature in paroxysmal nocturnal hemoglobinuria, and it seems like they've often used that through pregnancy. So some people have continued it because there is a big risk if you stop medications. It's not really a good option in NMO. So I think I would use one of those 3 options, for pregnancy. Great question, though. Thank you.
Thanks a lot for that talk. Would you agree that preventive treatment would be lifelong for these patients?
I think so. That's my current approach. I suppose if a patient is developing a lot of side effects of medication, then you might have to adjust. There's some literature, Hans-Peter Hartung showed the extended interval dosing of the B-cell treatments. That might be an option in patients who've been very stable for a long period of time. Some people have said, well, if they go antibody negative, then is that a time when you can withdraw the treatment? But I think in our experience with some of the stem cell transplants, for example, those patients will transiently sero-revert to negative, and then many years later, many of those patients went on to have subsequent relapses 5 to 10 years later. So I do think it's a long-term treatment, but you'll have to benefit that, if there's a lot of complications of the treatment, then you might have to decide, do you lower the dose? Do you do extended interval dosing or something else? Some patients have long periods of remission. We don't really understand it, but you're kind of playing with fire a little bit if you do that. And some patients have had very devastating relapses. There is a lot of accumulating disability. So in something like MOGAD, where patients recover much better, it's much safer to be able to stop a treatment than it is in aquaporin 4 positive NMOSD, or even in MS. Patients tend to have less severe accumulation of disability with one attack. Yeah. Thank you.
Thank you very much, Professor Eoin, for your wonderful presentation. It's truly enlightening our discussions. So let's show our appreciation in a usual way.
So it's with great pleasure that I introduce our next speaker, Professor Kazuo Fujihara. He's a neurologist and has mainly worked in the field of multiple sclerosis, neuromyelitis optica, and related immunological disorders. He's a member of the International Panel on Diagnosis of MS, NMO spectrum disorders, and MONC antibody-associated diseases. He is President Emeritus of Pan-Asian Committee for Treatment and Research in Multiple Sclerosis, immediate past president of Japanese Society for Neuroimmunology, an honorary member of the Association of Sri Lankan Neurologists. He is going to give us an overview of the new diagnostic criteria of NMO spectrum disorders. Over to you, Professor.
Thank you very much. Can you hear me?
Yes.
Okay. Well, thank you very much for the kind introduction. And I'd like to thank Dr. Bimson and Ayaka and the other organizers for this kind invitation. So in this presentation, I'd like to talk about an overview of the new diagnostic criteria of NMOSD, which is called IPND 2025. So the new diagnostic criteria has not been published yet, but last year in the SLCTRIMS meeting held in Barcelona, our leader, Professor Dean Wingerchuk, presented an overview of the new diagnostic criteria. So I'd like to increase the overview and share the data with you in this presentation. So these are my disclosures. So let me start with this, the very basic facts of NMOSD. So it's associated with aquaporin 4 IgG, and it's essentially an astrocytopathic disease. Definite female preponderance is seen, and the onset is on average 40, but the onset age may range from less than 10 years old or to even 90s. And essentially the clinical course is relapsing, and disability is essentially attack-related. Although in recent literature, there may be some slow progression in NMOSDs. So these are the typical features of MRI. Professor Eoin Flanagan already presented many of these, but optic neuritis is usually severe, and it could be bilateral. Optic chiasma may also be involved. And acute myelitis is also very severe, transverse, and it's often longer than 3 vertebral segments. And as for the brain syndrome, the area postrema syndrome, manifesting intractable hiccup, nausea, and vomiting is the commonest phenotype. But occasionally, the patients may become very sleepy, like narcolepsy, and bilateral hypothalamic lesion may be seen in this patient. And just like a narcolepsy, in the CSF, orexin A level is quite low. And this patient developed confusion, and you can see the very extensive white matter lesions. And this is also a part of NMO syndrome. If untreated, if not treated properly, NMOSD usually carries a poor prognosis. Up to 40% of the patients may become legally blind, at least in one eye, after 5 years of disease onset, and up to 20% of the patients may require a walker after 5 years of onset. And within 1 year of the onset, and up to half of the patients may require hospitalization. And most of the patients, if not all, are positive for a pathogenic aquaporin 4 IgG. And many patients may experience relapse if untreated within 5 years of the initial attack. So early diagnosis and early treatment start is critically important to improve the long-term prognosis. So on the left-hand side, you can see the population-based prevalence studies of NMOSD in the world. And unlike MS, the prevalence of NMOSD may be higher in Black population, East Asians, and Latin Americans in comparison with white populations. And unlike MS, there's no latitude gradient in terms of the prevalence. there are some longitudinal prevalence studies, and all of them showed demonstrated an increasing prevalence over time from 4.2 to 11.5, from 0.9 to 4.1, from 3.3 to 4.7 per 100,000 populations. But in early years, this increasing prevalence was likely due to increased detection and a changing definition from NMO to NMOSD. And but more recently, improved survival may play a role in this result. So this is the evolution of the clinical concept of NMOSD. And in 1999, the Mayo Group published the first diagnostic criteria. And at that time, NMO was considered as the optic neuritis plus myelitis plus no other CNS disease. However, then the aquaporin 5GG was discovered, and eventually the new concept NMOSD was introduced. So the patient may develop both optic neuritis and myelitis, but some of them may develop only relapsing optic neuritis or relapsing longitudinal extensive transverse myelitis. So 10 years ago, the new diagnostic criteria of NMOSD was published. And in this criteria, the diagnosis of MS and NMOSD was stratified into two groups, AQP4 positive NMOSD and AQP4 negative NMOSD, or unknown serostatus. For seropositive NMOSD, you need only one core clinical characteristic, either optic neuritis, myelitis, or brain syndrome. And the patient should be positive for AQP4 IgG, and you should exclude alternative diagnoses. As for AQP4 antibody assays, live cell-based assay is strongly recommended. But as Professor Eoin Flanagan already mentioned, a rapid immunoblot was recently published, so it may be used in the near future. And as for doubly negative NMOSD, very nice review article by Jackie Palace's group was recently published, and it seems this entity is relatively rare, and it seems to be a syndrome rather than a single disease. I will mention them a bit later in my talk. So how we decided to revise the criteria. So 10 years ago, IPND 2015 was published. And then in the year 2020, in February, European NMO meeting was held in Berlin. In Asia, COVID-19 was already prevalent, but it had not reached Europe yet. So none of the participants were wearing the face mask. By the way, during my flight to Europe, I was wearing the face mask, but when I arrived in Europe, I decided to remove it because no other person was wearing the face mask. By the way, during the meeting, the survey results on unmet needs in NMOSD was presented, and the majority of the participants said it's seronegative NMOSD. However, some of the seronegative NMOSD criteria were met by more positive patients. So in order not to cause confusion in the community, so we decided to define MOGAD first. And a few years ago, the first ever international diagnostic criteria of MOGAD was published. But the meetings were held during the pandemic. So before the publication of the paper, we never met in person. And I think we met more than 70 times via Zoom. But after the publication of MOGAD, the diagnostic criteria in 2023, we decided to revise the diagnostic criteria of NMOSD. So this is IPND 2025. And the last year in Barcelona, during the SLCTRIMS meeting, Professor Dean Wingchuk, who led the IPND, presented the overview of the new diagnostic criteria. Again, the new diagnostic criteria has not been published yet. So this is an overview of the revised criteria. So this group is a big organization, more than 130 clinicians and scientists got together to develop the new criteria. The steering committee is composed of 26 members, and there are 6 focus areas, namely clinical, serology, imaging, biomarkers, nosology, and the seronegative groups. And more than 60 special advisors and international consensus faculty also joined the group. And we used the systemic literature search by Covidence, and we reached consensus via modified Delphi and RAND UCLA appropriateness methods. So let me explain the one focus area by one. The first one is the clinical. We decided to add acute brainstem or cerebellar syndrome to core clinical characteristic. And as for specific manifestations, we decided to add paroxysmal tonic spasm and the neuropathic pruritus as a relatively unique manifestations of NMOSD. And the diagnostic criteria can be applied to both adults and children. So this is an international collaborative study on brainstem manifestations in AQP4 positive NMOSD. And as you see here, the vomiting and hiccup are probably related to area postrem syndromes, the commonest brainstem manifestations. But as you see here, oculomotor dysfunction, pruritus, hearing loss, facial palsy, trigeminal neuralgia, vertigo, and other brainstem manifestations were seen in a small number of cases. But as for painful tonic spasm, it may be seen in 1 out of 5 patients with NMOSD. But if you focus on longitudinal extensive transverse myelitis cases, more than 60% may present with this symptom. As you all know, carbamazepine is usually effective, but some patients may not tolerate carbamazepine. And there are some case reports on the efficacy of lacosamide and topiramate in patients who did not tolerate carbamazepine. But painful tonic spasm is not the movement disorders in NMOSD. Recently, the systematic review was published, and although the painful tonic spasm seems to be the most common movement disorder in the disease, but as you see here, some other movement disorders may be seen, including ataxia, tremor, restless leg syndrome, fixed dystonia, and so on. And as for pruritus in NMOSD, 26% may show this symptoms, but in comparison with MS, pruritus in NMOSD may be 10 times more prevalent. As for the location of the pruritus, one study shows that it's the most commonly seen in cervical dermatome, followed by cervical thoracic region, trigeminal nerve, and then lumbar region. Next focus area, the serology. So serum is the recommended testing sample. And as I already mentioned, live cell-based assay is the reference standard. But you should use the best available assay. And probably it is important to note that the seropositive fixed cell-based assay result does not require confirmation. So it means same high specificity as live cell-based assays. ELISA is not recommended. If the result is obtained with ELISA, the result should be confirmed ideally by live cell-based assays. Very unfortunately, Japanese government has formally approved ELISA. So the new criteria will send a strong message to Japanese government. I hope they will change their minds. But probably the reason why the Japanese government formally approved ELISA is that the quality control of live cell-based assay may not be so easy. They tend to approve the kits. So that's why probably they approved ELISA. But they should change their mind after the publication of the new criteria. You may need to retest future samples if initial sample tests are negative and assay was not live cell-based assay, or sample collected outside of acute attack period, or sample collected after potentially interfering treatments like plasma exchange. So this study is done by Dr. Patrick Waters of Oxford, and he compared the 6 different assays to detect AQP for IgG. So as I said, live cell-based assays are the most sensitive, and ELISA is much less sensitive. Although in this study, the specificity was 100% in all cases, but as Professor Eoin Flanagan already mentioned, ELISA may generate false positive. So it may be low positive in typical MS cases and other disorders. So you should be very careful about it. A few years ago, Australian group also compared the sensitivity and specificity of various AQP4 antibody assays. And although I do not go into the details, but they concluded that cell-based assays are sensitive and highly specific and performing better than tissue-based assay and ELISA. And also, they concluded that a fixed cell-based assay showed nearly identical results to a live cell-based assay. So this is a figure generated by this focus area group members. So live cell-based assay is the first choice, and the second choice is fixed cell-based assay. And ELISA is the third choice, which is not recommended. And depending on the results, you may make a diagnosis of seropositive disease or seronegative syndrome, or depending on the situation, you may need to test or retest or confirm the results with live cell-based assay or best available assay. Focus area 3 is imaging. So you need to obtain brain and cervical and thoracic spine in all patients with suspected NMOSD. And in patients with suspected acute optic neuritis, you should obtain orbital MRI with fat-saturated sequences and contrast. I guess Professor Letizia Leocani and Professor John Chen already mentioned OCT and VEP, so I did not go into the detail, but OCT and VEP may be used to confirm optic nerve abnormalities to make a diagnosis of NMOSD. And OCT showing bilateral or severe unilateral neurodegeneration with temporal sparing should prompt AQP4 antibody testing. As for relatively unique MRI patterns of NMOSD, 2 patterns were added. Brainstem for third and fourth ventricular, periventricular regions, cerebellar linear ependymal enhancement, and as for spinal cord MRI, bright spotty lesions associated with the LETM. So let me show you the difference between the fat-saturated image and the standard T2. So here's a fat saturation and the standard T2. As you see here, fat saturation eliminates signal from orbital fat. So it leads to the clear visualization of hyperintense inflamed optic nerves. But on the other hand, in standard orbital CT, orbital fat is very bright, and it may mask hyperintensity of optic neuritis caused by swelling and inflammation. So fat sat should be used for patients with suspected optic neuritis. So yeah, here's MRI patterns in NMOSD with AQP4-IgG. I think Professor Flanagan already presented these images. So A is T2 lesion in left dentate nucleus of the cerebellum. B is T2 lesion in the dorsal pons of the fourth ventricle. And C is bilateral T2 lesion adjacent to the third ventricle. So many of these patients develop insomnia. And D is GAD-enhanced linear ependymal lesions along the ventricular surface. And E is bright spotty lesion in the LETM. Focus area is biomarkers. Extensive literature review was done by this group, but the conclusion was serum AQP4-IgG is the only required diagnostic biomarker. And as for serum and CSF GFAP, which is a marker of astrocyte damage, nearly 60% of the panel members consider that GFAP is a promising marker. However, more evidence will be needed to be used for the diagnosis. So that means routine serum CSF GFAP measurement is not recommended to support diagnosis. And likewise, serum CSF neurofilament light chain measurement is not recommended to support diagnosis. Many years ago, we reported a very high elevation of the CSF GFAP in comparison with MS. So all those cases with NMOSD were AQP4 positive. And MVP markers of myelin damage was also high in NMOSD, but compared to the remarkable high level of GFAP, MVP elevation was much less remarkable. Recently, a European group reported that in some patients with double negative NMOSD cases, GFAP may be elevated, and some markers of axonal damage may also be elevated. So they suggested that some of the cases with double seronegative NMOSD may have astrocytopathic disease. However, the histopathological data of double negative NMOSD is still lacking. So I think it's still premature for us to conclude that some of the patients with double seronegative NMOSD may have astrocytopathic disease. Focus area 5 is classification and nomenclature. So seropositive disease are formally separated from seronegative syndromes, and NMOSD with AQP4-IgG is distinct from MOGAD. It's obvious for almost for everybody, right? Seronegative syndromes are stratified into two groups: NMO-spectrum syndrome, like cases similar to 2015 definition. So in other words, they are close mimic of seropositive NMOSD. Descriptive clinical syndrome include remaining cases like isolated relapsing LETM or optic neuritis. But revised definitions and nomenclature are still in progress. So this is the figure of the revised classification. So this is the universe of central inflammatory conditions, and it's divided into seropositive disease and seronegative syndromes or untested syndromes. Among seropositive disease, So MOGAD is separated from NMOSD with AQP4 IgG. And seronegative or untested syndromes are classified into two groups, NMO spectrum syndromes and the remaining categories, as I mentioned in the previous slide. The last focus area is a seronegative disease. The focus area 6 members extensively reviewed the existing literature, and they concluded that the patients seronegative for AQP4 and MOG antibodies have not been shown to have the same pathobiology as NMOSD with AQP4 IgG in terms of CNS pathology, soluble biomarkers, and results of therapeutic clinical trials. For example, in satralizumab trial, some cases with seronegative NMOSD were included. But in those cases, satralizumab did not show clear therapeutic efficacy to reduce the risk. So what are the implications? NMOSD with AQP4 IgG is a disease, just like MOGAD. And patients with clinical MRI phenotypes that mimic or resemble NMOSD, but who tested negative for AQP4 and MOG antibodies have a clinical syndrome rather than a disease. So as I mentioned before, Jackie Pallis's group published a very nice overview of the double seronegative NMOSD. And again, it seems to be a relatively rare entity, and it seems to be a syndrome rather than a single disease, ranging from like a post-infectious monophasic illness to chronic or relapsing syndrome. Let me show you my own case of seronegative NMOSD. The patient was 52-year-old female. In the year 2017, she developed intractable hiccup and vomiting, so area post-traumatic syndrome. The next year, she became very sleepy, and bilateral hypothalamic lesions were shown by MRI. But for some reason, so area post-traumatic syndrome and bilateral hypothalamic lesions manifesting hypersomnia are relatively unique to NMOSD, and the combination of these two may be very unique to NMOSD, but for some reason, she has been consistently negative for AQP4 IgG or MOG IgG. So we cannot use the highly effective monoclonal antibodies approved only for AQP4 positive disease. It's a dilemma. So to conclude my talk, NMOSD with AQP4 IgG was separated from MOGAD and seronegative syndromes. And second, NMO spectrum disease for patients with AQP4 IgG. So it's not the disorders anymore. It's a disease, one disease. And live cell-based assay is the reference standard for AQP4 IgG testing. And at this point, no additional biomarkers are required or recommended for that diagnosis. Although further investigations will be needed for GFAP and others, including IL-6 and complements. And finally, revisions for seronegative and serountested syndromes are still in progress. Finally, let me advertise the meeting to be held next month in Japan. So European Charcot Foundation, in collaboration with European Network of NMOSD and MOGAD and Japanese Society of Neuroimmunology, a workshop on update on NMOSD and MOGAD will be held on February 13 and 14 in Tokyo. I hope Sri Lankan colleagues register for on-site or online participation. With that, thank you very much for your kind attention.
Thank you, Professor, for that excellent talk. In the interest of time, we can allow only one question from the audience if you have.
Thank you, Professor Fujihara, for that excellent talk and overview. If you had the choice in that last patient you showed us, would you treat her just as you would treat NMOSD?
Well, currently, she's treated with corticosteroid and tacrolimus, a calcineurin inhibitor. Well, rituximab has been formally approved in Japan, but again, it has been approved only for AQP4 positive NMOSD. So we cannot use rituximab for this patient. So that's why I decided to administer corticosteroid in combination with the tacrolimus in this particular patient. But it's a very difficult situation, as you can imagine.
So let's show our appreciation in the usual manner.
Thank you very much.